بسم الله الرحمن الرحيم. دلوقتي انتوا عارفين انا الدكتور مجدى عمر، استاذ طب الاطفال في جامعه اسكندريه. هنتكلم على الدايابيتيك كيتو اسيدوزيس which is very common emergency situation in diabetic children. Diabetic ketoacidosis referred as DKA, diabetes ketosis ketotic acidosis, diabetic ketoacidosis. Therefore, for diagnosis of diabetic ketoacidosis, we need blood glucose more than 200 milligram, and we should have a serum ketones more than 3 millimole per liter, or positive ketones in urine. We call it ketonuria. We have ketonemia and ketonuria. And acidosis referred to as blood pH less than 7.3 and serum bicarbonate less than 15 milliequivalent per liter. Diabetic ketoacidosis is common precipitating cause. Again and again and again, take care. It is common at presentation because of delayed diagnosis and delayed treatment. But in a non-diabetic child, it can occur due to infection, omission of insulin doses, psychic stress, or trauma or severe illness due to hyperglycemia is the sine qua non of diabetes. Therefore, insulin deficiency and increased counter-regulatory hormone will pave the way for increased for severe hyperglycemia by increased glycogenolysis, increased gluconeogenesis, and diminished entry of glucose to the cell. This will lead to hyperosmolality in the blood. This hyperosmolality will lead to several derangements in the homeostasis. It will lead to loss of water from intracellular and extracellular compartment, and it causes osmotic diuresis. Therefore, we will end with dehydration due to contraction of the extracellular fluid volume and electrolyte losses, sodium, potassium, phosphate, and magnesium, and therefore we might have hypovolemia shock, diminished glomerular filtration rate and pre-renal failure, acidosis, and azotemia or increase in the blood urea nitrogen. Ketosis means accumulation of keto acids. Keto acids include beta-hydroxybutyric acid and acetoacetic acid. Acetone is also increased and give a fruity odor to the breath, but acetone is not a keto acid. Actually, it is a buffer. Acidosis is the accumulation of keto acids due to increased ketogenesis due to insulin deficiency and diminished ketone body utilization. And in severe cases of diabetic ketoacidosis, we also have hypovolemia and dehydration. This leads to lactic acidosis. And a third mechanism for acidosis is you are pushing. This means that you are pushing hyperchlorides or excess chlorides during IV resuscitation. What are the symptoms of diabetic ketoacidosis in a diabetic child? Diabetes usually starts with polyuria, but when he starts vomit and have abdominal pain and started to be dehydration with deep and rapid respiration due to acidosis, that child is in diabetic ketoacidosis. Therefore, take care in a child with diabetic ketoacidosis if he develops signs of dehydration or develops respiratory distress and deep and rapid breathing or Kussmaul's respiration, or he started to vomit with abdominal pain, or there is finally there is altered mental state that correlates with the degree of hyperosmolality, which is very common in diabetic ketoacidosis. How to treat diabetic ketoacidosis? Number one and the most essential is to replace fluid and electrolyte losses Number 2, to correct acidosis and hyperglycemia, you need fluids and insulin. And we have to look for and treat any precipitating cause and complication. The child may die from the precipitating cause rather than from diabetic ketoacidosis. It is very important to look for any precipitating cause. He might have meningitis, he might have pneumonia, he might have any serious illness. Intravenous fluid is the mainstay of the treatment and first initial management. You have to rapidly correct shock and hypovolemia. We start in the first hour by giving normal saline 10 milliliter per kilo. This is a priority. And if still hypovolemic and hypotensive, you might repeat, but avoid overhydration. When you correct shock and hypovolemia, then the second objective is to slow correction of the deficit by providing the maintenance over 24 to 48 hours and divide the deficit or the amount lost over the same duration. We start aggressive and then end very slowly and conservative to avoid brain edema. How much deficit? This depends on the degree of dehydration. The same like acute dehydration complicating gastroenteritis. You might have mild, moderate, or severe. Therefore, the losses ranges between 50 and 100 milliliter per kilo. How much maintenance? A child needs water. For the first 10 kilo, he needs 100 milliliter per kilo. For the second 10 kilo, he needs 50 milliliter per kilo. After 20 kilo, he needs 20 milliliter per kilo for the remaining body weight, above 20 kilogram. A slow correction of the deficit. Remember that we started with saline because it is isotonic. But what to give during the second phase, which is the correction of the deficit and provision of the maintenance. Usually we start with half-strength saline. And we continue in this saline until the blood glucose starts to decline to less than 250 milligram. Then we add 5% glucose in half-strength saline. A full strength saline is 0.9%. Saline, this is saline. Half-strength saline is 0.45%. Potassium. We need to give potassium whenever there is no hyperkalemia and there is good urine flow. Then again, fluids in diabetic ketoacidosis. We start by saline or any polyelectrolyte solution like Ringer's lactate for shock and hypovolemia, and this is done rapidly. You have to be fast and aggressive when you are treating shock. Later on, after correction of shock, you have to be slow and you have to go down with the strength of the saline to half-strength saline until blood glucose is less than 250, and then you add 5% glucose to the saline. And potassium need to be added according to monitoring of potassium. Insulin therapy. We give insulin therapy by continuous infusion, not by bolus. 0.1 unit per kilo per hour. We start by 0.1 unit per kilo per hour, starting from the second hour, so as to avoid sudden drop in blood glucose, which might put the child at risk of brain edema. You give 0.1 unit per kilo by continuous infusion. If you do not have an infusion pump, you might give hourly intramuscular insulin, regular insulin or rapidly acting insulin, 0.1 unit per kilo per hour. But nowadays, pump is everywhere. After correction of acidosis, then we start to give subcutaneous insulin, 0.1 to 0.0 unit per kilo, intramuscular or subcutaneous. Of course, intramuscular, if we started early, if we cannot give intravenous insulin during the acute stage, intramuscular is preferred. But even subcutaneous can work. But during the maintenance phase, we give 0.1 to 0.2 unit per kilo subcutaneously every 6 hours. We adjust the dose during this transition from blood glucose for blood glucose when patient tolerate food, shift to 6 hour subcutaneous before meals. Blood glucose should be kept between 100 and 180 milligram before meals during this stage. Don't give bicarbonate for correction of acidosis. It should not be a routine because it might lead to complications like paradoxical brain acidosis and might augment hypopotassiemia. You give only if blood pH is less than 7 and in intensive care, and never by bolus. By very small dose, 1 to 2.5 milli equivalent per kilo as intravenous drip, very slow intravenous drip. Thank you.